This is Mary Shotwell recording the first lecture in Introduction to Evidence-Based Practice. For the most part, I'll be going along with the chapter, but I've added some additional slides from the book, Evidence-Based Rehabilitation, A Guide to Practice by Mary Law, who's an OT, and Joy McDermott, who's a physical therapist from McMaster University in Canada. A lot of this lecture was taken from Dr. Tamara Mills, who's taught this class in the past, and she shared her lecture notes with me, and I've modified it. So slide 2 is the introduction to the class, and so we want to think about how do we know what it is we know? How do we know what is real? So we hear things on the news, the best treatment for X, Y, and Z. And just because we know the best treatment, does that make it so? What does it mean to know something? Well, we, know something based on personal experience, but we also know something based on, research as well. But unfortunately, a lot of what we do in OT is passed down by word of mouth from therapists just based on experience, and it's not really evidence-based. So the third slide talks about, can you trust your own experience? Can you trust your own opinion? Why do we believe what we believe? I mean, get a little philosophical here, but expertise is a good thing. Experience is a good thing. People tell us stuff, right? We're inundated with media. And how do we know what is true based on what we're reading? So we all know about science, right? You all know about, the scientific method. Well, the way we know what we know in all professions are that, there's a set of methods we use to study certain phenomena. We have a reliable base of information. That information or that data helps us to develop theories to explain what it is we're seeing. So in your foundations class, you're going to have you're going to learn about all these models and theories and frames of reference. Well, where did they come from? There are certain theories in our profession, like MOHO, Model of Human Occupation, that has a lot of evidence to support it. There are other theories or models of practice in our profession that actually, although used a lot, for example, sensory integration theory, does not have an inordinate amount of evidence to support its use in practice. So, we need to use the scientific method. Our field still needs more research, more theory development, and more evidence to support its practice. Obviously, the scientific method is the first thing. We identify the problem, we develop a hypothesis, we conduct research to test that hypothesis, and we analyze results. And of course, really important is to disseminate those results in scholarly publications. And in our field, we may not have as much scholarly publications as in other fields, although we've improved immensely in the 30 plus years that I've been a practitioner. So, I'm sure it'll improve in your lifetime as an OT as well. The next slide talks about what is a scientist. Well, scientist is somebody who does science, right? But you are now a scientist. You are now becoming an occupational scientist. You are going to look at things in a new way because we're giving you a language to look at people and the way they do daily life occupations. It drives my husband crazy that I'm always analyzing the way he does dishes, the way he cooks, the way he does this, that, or the other thing, because of course I do it perfect. But OTs just naturally analyze activity. We analyze occupation. And we look at, is there a different way to do it? Is there a better way to do it? How would I do it if I had a disability? So this semester you'll be taking kinesiology and you'll look at the biomechanics of how occupation happens and you'll be analyzing that. And then in foundations, you'll be looking at more the sociocultural way in which people do occupations. So it's really kind of cool. This whole semester, you're going to be really looking at how is it that I look at occupation? And am I really a scientist? Well, you are. And so I now dub you an occupational scientist. It's official now. But we really want to really, in this class, get good at defining what a problem is, seeking out and finding relevant information, and then testing our hypothesis. The next slide talks about how it is we do science. Well, in a quantitative world, we might measure variables, look at relationships between them, look at differences between them. We might conduct controlled experiments and look for causal relationships or connections. But we could also do qualitative research, which you may know less about. Qualitative research is where we're looking at meaning. And in quantitative research, our goal is to usually study a whole bunch of people, but typically not as deeply. So we don't understand the why behind people's answers to a survey question, for example. But when we do qualitative research, we understand, or we're seeking to understand, the meaning. How is it that people make sense of occupation? How is it that people experience daily life with a disability, for example? So it could be quantitative, it could be qualitative. And what matters most is your research question. Not Don't say to yourself, I like quant because I like numbers, or I like qual because I hate numbers. Your research question should drive your methodology. You can always get help by experts in methodology. What's more important is to formulate the question that is appropriate for your setting and population. The next slide talks about basic and applied research. And by the way, some of these slides come from Borden's and Abbott, which is a sort of foundational text in research methods in psychology. Some of you may have had that text in previous classes. Basic research, or you might hear people call it bench scientists. That would be like your lab kind of sciences, studies designed to evaluate theories or postulates, acquire information about a phenomenon, is basic research, little emphasis on application to real life. So you might read studies and you'll critique them out the wazoo because you'll say, well, that isn't real world. That is in such a controlled laboratory setting. So, for example, one of my lines of research is on hippotherapy, therapy using horses. Um, And so there are some of these studies that, quote, they showed an improvement, but the client or the participant was on a simulated horse, like a barrel. I also do research in driving, and there's some studies that use driving simulators. And so people would say, well, that's great for internal validity because it's a controlled laboratory environment, but those simulated experiences do not translate into real world, dynamic, ever changing environments. So, basic research is really good when we're initially studying the problem, but there is this new concept called translational research, and that is where we translate the basic research or the bench science into real life practice. And that's the next slide that talks about applied research. And more of what OTs do is applied research. So that's a good thing. But we still need the bench science people too. So we need a combination of these types of research. There is overlap between basic and applied research. And nowadays, a lot of journals are, they'll look at your study and say, can you please translate this into real world problems? So, just so um, more current research is always asking, how do we apply this to real life, everyday practice? The next slide talks about the history of evidence-based practice, and this is sort of in your chapter, I guess it's on page 2. And that talks about where did it start? Well, it started at McMaster University, which is where these two women, Law and McDermott, work. So that's why they're the authors in our field. From David Sackett, who was an MD. And it emerged from how do we make clinical decisions and how do we use the scholarly literature to evaluate and help us make clinical decisions. It is evidence-based medicine or practice was named one of the top 10 developments in the history of medicine. So it's really in, your lifetime or my professional career in the 80s going up to current day where we said, what is the level of evidence? Is this evidence good? Should we be basing a clinical decision on that? It's a little easier with a drug, right? Well, like we do a randomized controlled trial on a drug and you have a control group who gets the placebo. But in what we do in occupational therapy, it's quite hard to design a randomized controlled trial. And we'll talk more about what that is a little bit later. Definitions of evidence-based medicine or practice. You'll see different definitions, but basically it says, what it aims to do is critique the accuracy, the precision of studies, and to evaluate them and tell us, how do these studies apply to clinical practice? How do these studies apply to our patients and what patients value? So it's not just about critiquing the science, it's combining what the patient and the society at large, what matters to them. And we have a graphic to show you on that in the next couple slides. Part of evidence-based practice on the next slide, called Development of Evidence-Based Practice, talks about that we have strategies for tracking down and appraising evidence for its validity and its relevance. This concept of systematic reviews. So in what you're studying, if you can find a systematic review or something called a meta-synthesis, which is qualitative literature, then someone has done the work for you in evidence-based practice. And in our field, we have, you all have to become members of AOTA, and you can find evidence-based guidelines on certain topical areas in our profession, or these things called critically appraised topics. And that's where someone else has synthesized some of the research in our field. And so it is a systematic way to find, critique, and evaluate the available evidence in a certain profession, and then to apply it to a patient population and make some decisions about the clinical bottom line. Would you or would you not do that intervention? Some other definitions say that it is the conscientious, explicit, judicious use of the best evidence in making decisions about the care of patients or clients. And I like that definition because it takes into the fact that these are human beings we're dealing with as well. It also takes into account that it requires you to read the literature all the time. So in this program, we require you to join GOTA, AOTA, and so forth. And, we do it to start your socialization process to the profession. But it is up to you to continue the membership after you leave here, so you have access to the most current information in our field and the most current journals. So when I get my AJOT every other month, I kind of skim the articles that are useful to me and skim the abstracts. So I'm always kind of current in what's going on in our field. I don't read all the articles, but I try to keep abreast of topics in my field, even if I'm not practicing in that area. The next slide gives another definition by Rosenberg and Donnell. It says the process of systematically finding, appraising, and using contemporaneous research findings. So I like that, the appraising piece of their definition. The next slide this is from OTs. It's considered to be a combination of information, what we know from research, what we've learned from clinical wisdom, and what we've learned from the client and the family. So this is a typical OT view of the world. We combine science, clinical experience, and the client's lived experience. So I think that's important. That's OT or rehab twist on evidence-based practice. The next slide says that EBR, evidence-based rehabilitation, is an adaptation of EBP in rehab. And that's where we say that in rehabilitation, particularly people with disabilities, their lives are complicated. It's a lot more complicated to have a catastrophic brain injury or spinal cord injury or cerebral palsy or autism than it is to have I don't know, a fractured finger, for example, although that can be complicated too. But that, when we're dealing with the study of occupation and how it is people do everyday activities, that's different than looking at lab values for a test related to diabetes. So I hate to use a trite phrase to say what we do is complex, but it kind of is, because we're dealing with human behavior, habits, roles, routines, and the fact that everybody does stuff differently in their life. The next slide talks about evidence-based rehab, then it's a powerful tool, but it's easily misunderstood. Um, but it could be very useful not just for clinical things, but also for managerial support. So the manager says, "Why does it take you so long to do this evaluation?" When we're using evidence based rehabilitation, we could show management, "Hey, this is why it takes me so long to do this stuff." This is what I was telling you earlier, that we would have a slide based on evidence-based practice, particularly in our field, is based on our clinical expertise, the best available research evidence, information from our particular context, and the client values or circumstances. So the intersection of those four circles is where we would, place evidence-based practice. This is just a slide that talks about different evidence-based practice in the news. Excuse me, I'm going to cough. And that, it's always being updated. So you don't have to click on all those, but a lot of this is telling you what the barriers are to evidence-based practice. The next slide is a little redundant. It just says, what does evidence-based help us do? Well, it really helps us to think about, why am I doing what I'm doing? Or am I doing that just because someone told me I should? Was it passed down by word of mouth? Or is there evidence that can help me do it in a more effective way? And I want you to continue to think about that throughout your career as an OT. Don't just do something because it was passed down by word of mouth. Common myths about evidence-based practice are on the next few slides. Evidence-based practice does not ignore, clinical experience. We take it into account. The next slide says it's not client-centered. You saw on the Venn diagram, it does take into account the client's situation, preferences, and values. We can't possibly do it as another myth. And it is not, the way you could do it in a clinical setting is through a journal club. If you work in a hospital, typically there's a medical librarian that can help you find articles on a specific topic. We're going to teach you in this class how to set up an evidence-based matrix, which might include just 3 or 4 articles on a given topic. So, it doesn't have to be that complicated. There are also databases like the Cochrane database that has done some of your work for you. So, you don't have to be reviewing articles all the time once you're in clinical practice. There are people who have done that for you sometimes. It doesn't ignore good evidence. It takes into account all evidence. So it doesn't only reject things that are a randomized control, beyond a randomized control trial. This evidence-based practice takes into account all levels of evidence, with the highest level or the best level being a randomized controlled trial, but you're not going to see that many of those in our profession. It already exists. Well, evidence-based practice is in existence, but it always is evolving, so that's why it's a never-ending, you never finished evidence-based practice. It is going on all the time. Really, in every profession should be doing some type of evidence practice. It is not a malicious tool of healthcare policymakers or administrators to reduce costs. It is really to provide the best available clinical and quality care to clients. It could be used, I guess, to cut costs. but it can also be used to say, hey, we're spending all this. So I guess it might be used to reallocate resources. There was a recent study that showed that OT is one of the most cost effective disciplines at keeping people from being readmitted to acute care hospitals. So, again, that's where we use the evidence to support our profession. Um, what is our tasks in evidence-based practice? First, that we are aware of it, that we consult with others, we consult with the literature, that we use our judgment to analyze that information, and that we're creative at presenting what it is we found. That doesn't mean we make up stuff, but the best way to present it to managers, to funders, to clients in a way that they're going to understand the evidence to support a particular intervention. The next few slides talk about how we do awareness, how we do consultation, how we judge the literature, and how it is we can be creative. Um, how it is we present the art and science of evidence-based practice. So we may want to present information in a different way depending on our audience. So we might make a brochure for family members or a website, but we may present it in a report format for insurance companies or legislators. What are the 5 steps? We have to develop a question first. Then we track down evidence. We critically appraise that evidence. We integrate and synthesize our appraisal into our particular clinical context or our patient's context. And then we evaluate the effectiveness of what we found and tell people what it is we do. And this is a graphic. This is from JAMA, and it's sort of the 5 A's. We start by asking the question. Then on the bottom of the slide, we acquire the information, we appraise it, we apply it to our particular situation, and then assess what it is that we would do. And this is a never-ending process because we're always coming up with new interventions or modifying interventions. Next slide, 33. This is going to be important, and we'll revisit this at another point. But you're going to see different levels of evidence, different classification systems, but 1 is the strongest, 5 is what we call the weakest. You may see letter grading, but 1 is a systematic review of randomized control trials, which we really don't have those in our profession. We do have a couple 1Bs, which are individualized randomized control trials. We do have 2As and we do have 3As, which are systematic reviews. Once we get down to level 4 and 5, they are more single case studies, expert opinion about things. So, they're considered weaker. And we'll talk more about these later on when we try to give you examples of the various studies at different levels of evidence. This is another way to look at the levels of evidence. You're going to be reading the Tomlinson article, and he uses kind of this pyramid. The bottom level is the most basic, whereas the top of this pyramid is the highest quality of evidence. And so if you can find the top 3 levels, someone has done some work for you ahead of time. And so those are things we would like to find when we are critiquing the evidence. So these 2 graphics, this slide and the slide before it are really good slides to sort of etch in your mind when you're classifying the levels of evidence. This last slide is just about different links in our fields that might help you critique the evidence and find articles. I think this is the last